Button. It's
Record.
Hi, I'm Dr. Arlen Myers. I'm President and CEO of the Society of Physician Entrepreneurs, and welcome to this session. I'm pleased to have a friend and colleague, Irv Stackpole, who has a long history of medical tourism and consulting. So, Irv, thanks for joining us.
Well, it's my pleasure, Arlen, and welcome to all of those who were intrepid enough to join us.
Yeah. So, Irv, why don't you just give the folks a little bit about you and your background?
Terrific. So on my background, and you'll hear my Boston accent at some point in time, so there's no sense faking it. My background includes a clinical background as a respiratory therapist. I started at the Massachusetts General Hospital and was fortunate enough to be invited to contribute to a seminal textbook in that field, which garnered the attention of executives at American Medical International, which is now Tenet Healthcare. I was recruited by them to lead up their training and human resources and then their business development efforts. I worked for them for a number of years, held a variety of positions, and that was my first exposure to international work, because at the time, Tenet was the largest investor-owned hospital group in the world. And so I was exposed to international work, and then through subsequent jobs, I was also exposed to other sectors in both US and international healthcare. So since 1971, I've been involved in a variety of virtually every vertical in the healthcare business. I got involved in medical travel, health tourism. In 2005, I was invited to do a feasibility study in Costa Rica for a very large retirement village. Along with other work that I've done lots of feasibility studies. And in the course of that work in Costa Rica, I met the economic development minister, and he said to me, this retirement for our country of Costa Rica, retirement is a very interesting business line, but what I'm really interested in is turismo médico, medical tourism. I had to ask the fellow who was there translating with us to ask him what he said twice, because I didn't understand it. Come to find out that shortly before that, an editorial piece had been published in NEJM, New England Journal of Medicine, that mentioned the term, and we were fascinated and began to research, and soon discovered that this was a nascent area of business development, and did networking and began to learn more about it and became fascinated with it. In fact, we were among the earliest, my company was among the earliest in the field. With my colleague Elizabeth Siemba, we wrote the very first book on marketing medical tourism in 2009. We just published a second version of that, the Handbook for Medical Travel Marketing, in 2021. And so that's my background. We've worked with governments, destinations, individual entrepreneurs. We've worked with a variety of providers, destinations, and governments in the field.
Right. And as you're probably aware, one of my first companies was a medical travel company. So I sort of got involved in, I didn't know what I was doing. And it's in my failure resume, which I'm very proud of. But so I've had a longstanding interest in this. So thanks for doing this. So just to set the stage, there are various terms for medical tourism, medical travel. Some people like it, some people don't. But for the purposes of this discussion, we'll call it medical tourism. And you can like that term or not, but that's what we're going to do. And second point is, just for those that are watching this information, typically medical tourism is defined essentially three ways from the perspective of the home provider. So in the case of Costa Rica, There is outbound tourism, which means if you're a Costa Rican person and you're seeking care somewhere other than Costa Rica, that's outbound. If you're a patient in Costa Rica, or you're a government of Costa Rica and you're seeking patients to come to Costa Rica, as you've just described, then that's inbound. And then if you are, as in the United States, for example, if you're a patient and you come to see me and you say, some complicated thing or whatever, it doesn't even have to be complicated, whatever, and you say, I'm actually seeking a provider other than you for whatever reason outside of Denver, can you send me to some other place in the United States? Then that would be domestic. So essentially we're talking about outbound, inbound, and domestic. And the final point is that there are many, many stakeholders in this game, but the fundamental ones are the patient, the place that the patient is going to, that is the Economic Development Agency, the Ministry of Tourism, a hospital system, whatever that is organizing and providing this care. And then there's the referring doctor or receiving doctor, the physician. So let's start off with, since this is the Society of Physician Entrepreneurs and we're talking about physician entrepreneurship, let's start off with what do doctors, or what has been your experience? What are the do's and don'ts of a physician who is a surgeon usually, but not necessarily? And let's just, again, confine this to medical care, because we could talk about drugs, we could talk about dentistry, we could talk about a whole lot of other stuff, but let's just confine this to traditional care from physicians, medical doctors. So what are the do's and don'ts of a medical doctor, for example, in Costa Rica, South America, Mexico, you pick your place, as far as building and a medical tourism practice?
Well, thanks. It's a really fascinating question, Alan, that the descriptions and definitions you set out previously direct the question. So for the doctor in Costa Rica, and I think if we took two doctors, one in Costa Rica and one in the United States, we could have a very interesting conversation about where the opportunities are for those respective individuals and would-be business leaders, so as entrepreneurs. I'd like to reframe this just a little bit. You mentioned inbound, outbound. You mentioned the domestic. So that is a typical structure for understanding these practices. I would submit that a slightly better structure is to talk about cross-border trade. Because what happens when we talk about medical tourism is that we typically think of an individual crossing a border. Just in the scenario you described, Arlen, an individual comes to you and wants a consultation about epigastric pain and doesn't understand what the issues are, but she's done some research and she thinks that there's a treatment at the Cleveland Clinic, but she comes to you in Denver first. She then goes to Cleveland in order to have this other diagnostic procedure for her presentation, her pain. That is indeed cross-border trade between Colorado and Ohio, or wherever, whichever version of Cleveland Clinic she chooses to attend. That's a form of cross-border trade. Similarly, the doctors in the United States and the doctors in Costa Rica engage in some level of cross-border trade. This trade does not have to include the person actually traveling. In fact, if the doctor in Cleveland, if the Cleveland Clinic is smart, and they are, if the Cleveland Clinic is smart, they are attracting consumers from Colorado and many other states to engage in cross-border trade without ever moving. So our patient, our theoretical patient here, may have the diagnostic procedure from the Cleveland Clinic by the doctor at the Cleveland Clinic, from the team at Cleveland Clinic remotely. And that is a form of cross-border care. But let's just take a typical case of a plastic surgeon, cosmetic surgeon in Costa Rica, who is treating individuals who cannot afford, or for whatever reason, don't want to have cosmetic procedures done in Colorado or Texas or Florida. These consumers travel to the destination, receive their services, and then go back home. The important thing for the practice in a destination that wishes to develop its expertise is focus. Now, entrepreneurs are noted for their risk profile. That, in fact, is what defines an entrepreneur, is someone who is willing to engage in the risk associated with starting something new or developing a business. The important thing to recognize in developing a medical travel business is that the doctor, the surgeon, should focus on specific procedures among a specific kind of consumer, specific segment or subsegment of consumers. That will give the surgeon, that will give her the opportunity to really develop a deep niche. That's really what's important in these markets in general. So often when we talk to folks on initial interviews or during the discovery process, I have heard literally dozens of hospital CEOs, CMOs say to me, "Oh, we do everything. We do it so well." Well, you may be able to do everything, and I believe that you do it. I will take it at face value that you do it well, but you can't do everything from the consumer's point of view. You can't do everything from the intermediary's point of view, which we can talk about later. So the principal first step in any successful journey is to decide, I'm taking this step and I'm going in this direction. That's really the first strategic tip. You asked me for some tips.
Right.
And that's
So
it. Focus.
another way of putting this is be really good at something. and stick with that something. And
Yeah.
that argument could be made of most hospitals in the United States. And there are examples, Schuldeis for hernias, people, those kinds of, and they do remarkably well. And they're so,
Yes.
yeah, that's a good tip.
Yeah. And not only, it doesn't say that if you're developing a business, and I'm speaking now to the doctor, right? It doesn't mean that you can't be opportunistic. It doesn't mean that if you're going to focus on a particular type of cosmetic procedures, eyes, let's just say, you're going to do blepharoplasties and some other things. If you're going to focus on that and somebody comes to you and needs or wants a reconstruction, it doesn't mean you can't do it. It just means you develop a deep vertical niche, just as you said, Arlen, in a particular area, and that gives you an opportunity to develop a practice. Now, the assumption behind my admonition, it's really not a tip, it's an admonition. It's after doing this now since 2005, I can tell you that this is a fatal error that I've seen over and over and over again. And the critical piece about focusing is central to digital marketing. Your marketing, and I'm speaking to the doctors now here in the audience, your marketing is going to be digital primarily. And what we know about digital is Google, and Google rules the roost. There's been quite a bit of buzz recently about the vulnerability of the big tech companies to constraints and changes in their algorithms and rules about how they collect data, use data, direct consumers, et cetera. That's very interesting, but it's secondary. Right now, today, and for the foreseeable future, at least for as long as it takes you to establish your smiling eyes cosmetic clinic, as long as it takes to do that, Google is going to be the dominant channel through which your consumers will come. Now, secondary channel is, of course, what we call med to med, which is doctor to doctor, which basically, Arlen, is what we're doing here. We're having a conversation, medical person to medical person, about a particular category of consumers. And that's exactly what I would encourage any doctor in any destination location, whether it's Colorado or Costa Rica, I
Right.
would urge them to develop that kind of channel as well.
Yeah, so let me just interrupt. So great points, but let me just interject something. So this company that I was talking about that we created was called Medvoy, Medvoy. I don't know whether you remember my doing
I
that,
do.
but this was many, many years ago. And the basic idea was, as you just said, the traditional model of medical practice when it comes to second opinions or referrals is physician to physician. And the medical tourism industry evolved into a patient self-referring via a website. And now things have changed a little bit. For all intents and purposes, though, that's still the way it works. As you said, people search, 99% of people, wherever they're going, go to Google or something to get information about what it is that's bothering them before they go to see the doctor. So we're all sort of primed to use, now it's large language models and AI and all that. We can have that conversation. But the point is, from the physician perspective, doctor to doctor communication and referral is sort of the model. So we tried to create a company that did that. We tried to create a physician to physician referral platform, and it didn't work. Now, we can get into a whole lot of things about, one was because I didn't know what the hell I was doing. But secondly, there were a whole lot of fundamental issues, the head of the market, and I didn't understand the customer, all the stuff that goes into why a startup fails. So, and fundamentally, it failed because, like most startups, we had a product no one wanted to buy. So my point is that when it comes to referral, physician to physician referral, so I'll give you an example. I recently attended a conference in Tijuana at the invitation of the Northern Baja cluster, which, as you're aware, has a fairly active medical tourism cluster, ecosystem, when it's a whole nother conversation, whatever you want to call it. It is essentially, as you referred to, cross-border trade between San Diego, Southern California, and Northern Baja. That's the gist of it.
Mm-hmm.
And they were sponsoring the conference to promote the Northern Baja medical travel cluster, to encourage more Americans, or wherever they came from, outside of San Diego, to come to, in this case, Baja, but all the rest of Mexico, because as you're aware, there's 10 or 15 different medical tourism clusters throughout Mexico, let alone South America. Well, my point is that doing that means you have to overcome significant barriers to physician referral. And those barriers fundamentally have to do, particularly in cosmetic surgery or other elective cash paying procedures, there's a whole list of them, but not the least of which is interoperability of data and information, and the whole issue of the reluctance of a referring physician to send a patient to another physician outside of the country for many, many reasons. Everything from they just don't think it's the right thing to do, to greed, to you hurt my feelings. I mean, it's just the way it is, you know, turf wars and just because we're humans. But the main issue really had to do with malpractice. So if you referred a patient to another doctor in another place, and the patient had the procedure in the other place, came back home, in this case, let's say Denver, and things didn't work out so well, they knock on my door and say, Dr. Myers, you sent me to Dr. Stackpole, and he screwed things up. And now I want you to fix it. That's a big problem. So those are the issues that you sort of from now, that doesn't mean you don't do it, because there's a lot of folks that are doing this. So how do you respond to that? So how do you, when you're advising physicians in Costa Rica to attract patients in Denver, given the issues I've just described, what do you recommend?
Well, you've painted, again, Marlon, you've painted a complex picture, and I'll try to sort the things out. You've selected an example, a framework between the United States and Mexico that's particularly fraught. And it's particularly fraught at this point in time because of the geopolitics. And it's also particularly fraught because in many ways, Mexico, the states of Mexico and Mexico itself have not done a very good job managing its public image, and in some ways has not done a good job protecting visitors or citizens. And that creates a patina. And please forgive me if I sound hyper analytical here or cold or unfeeling. I am not any of those things, but I have to peel apart the onion here to better understand what's at the core. Understand that the channel between San Diego, Southern California, and Baja, that part of Mexico, is a very well-worn channel. There are more, I will say categorically, there are more Americans traveling from that part of the US to that part of Mexico to consume medical services and return home than any other pathway in the United States, than any other pathway into and out of the inbound and outbound, to use your terms, in the United States. It's a well-worn pathway. So what that means is that there's lots of infrastructure. So there are lots of services and providers on the Mexican side who are accustomed to receiving these consumers. And there are lots of, I won't say lots of, but there are providers on the US side who are accustomed to doing the handoff between the US and Mexico. The issue of data is extremely fraught. There is a segment of the Centers for Medicare and Medicaid Services in the United States, CMS, which is the it's the big one in the United States. That handles everything. It's really the single payer in the US. They have a data management office that's just actually been reunited into one. So they've got a single data management office, and they have a special task force to look at data integrity exchanges between the United States and Mexico. And that gives you an idea of the scale of this issue. So data management is, yes, an issue. But typically, it isn't the data exchange, it's the consumer who travels from the US to the Mexican provider with her files under her arm or in her purse or in his bag, and they go with this information to receive the care. This issue of returning back home, when the consumer goes back home, and they're having the problem emerges is a problem in every regional market for cross-border trade in medical services in the world. It's an issue that hasn't been addressed, and it's an issue that I will say humbly, my team, my colleagues and I are trying to address by bringing principles of transitions of care, clinically proven, demonstrated principles of transitions of care to cross-border trade in medical services. Desperately needed.
Right. Let me just interrupt you. Yeah, let me just interrupt you a minute. Or Giselle, can you, I want to get to your questions. So can you introduce yourself and tell us who you are and where you're coming from?
Hello, apologies. I can't be on video because I'm actually trying to do two things at once. I'm kind of working and listening. I didn't want to miss the discussion. So my name is Giselle Metham, and I am the executive director and co-founder of Meta Health. We're a medical travel or medical concierge company based in the UK. And I was really interested to hear your description of the issue, which essentially is about clinical risk and who takes the risk, who takes responsibility for the risk, and who manages the risk.
Yes.
And where's the patient in all of this?
Yes.
But so you're based in the UK. Where in the UK?
London. So we work with consultants in London.
Right. So, so thanks for joining us, and it's great that you can lend this perspective from your end. My understanding is that about 15 to maybe even more, 20% of the total UK healthcare spend is in private hospitals, not the National Health Service or in combination with the National Health Service. And there are several international hospitals that are based in particularly London and places where people are more likely to avail themselves of this. Is that correct?
Yes, I mean, I don't have that figure to hand. What I will say is that we are very fortunate in that we do have an excellent public health system. I mean, people grumble all the time, but it's free at the point of access. And what we have in tandem is the private healthcare system, and it is probably about 20%. What's great about that system, that kind of healthcare ecosystem, is that the people, the consultants and the healthcare professionals that work in the NHS, as we call it, the National Health Service, are the ones that run the private healthcare sector, i.e. that work in the private healthcare sector. And what we have is a very well-regulated healthcare system, a lot better than many countries in the world. So we've got very good regulation, and clinical governance is always at the top of the list of priorities. So the reason why I mention that is because this means that the consultants and the other healthcare professionals that work in the national healthcare system automatically carry that training and that focus and that priority to the private healthcare system. And this means that if someone is on the waiting list for hip replacement or something on the NHS, and they decide either because they're insured, privately insured, because we don't all have to be, or they are self-paying, if they decide that they want to go over to the private healthcare system, they can easily do that. We also have quite a healthy medical tourism stream of people coming from abroad who come to the UK for private healthcare because they view the UK as a country that clinically is comparatively safe, as they would the US. So it is a mixture, and there are benefits to that.
Okay.
May I?
And just so we understand, Giselle, what is your background? Are you a doctor or a business owner, or what is your background?
I'm a qualified nurse by background.
Good.
And
Okay.
so I've grown up in the healthcare system
Okay.
in the UK.
And before I get back to you or to respond to her, your comment says you don't engage in outbound medical tourism for the reasons that we've discussed. But my understanding, and again, I've spent some time in England and through this thing, but I certainly don't know as much as you do. But the point is, there's a pretty robust cross-border exchange between the UK and many other countries that are outbound. For example, Eastern Europe for dental care, or other things that are not covered by the NHS that essentially are cash out-of-pocket expenses. Is that accurate?
Absolutely accurate. You always have people engaging in outbound medical tourism. We choose not to support that. So we have clients ringing us and asking us to recommend a hospital in Turkey or somewhere else to do cosmetic surgery. It's usually cosmetic surgery, bariatric surgery, dental surgery. We choose not to engage in that. So we don't support for the exact reason that you said. If we were to facilitate someone going over to Eastern Europe or somewhere else to have a procedure done, and there is a problem, then they're going to come knocking on our door saying, this is the person that you recommended. And so there's a reputational issue. And
Right.
because I wouldn't do it myself, therefore I can't ethically recommend that other people do it.
Okay, thank you. So Irv, you want to respond?
Well, to Giselle's fundamental point, yes, the issue of risk should be at the front of everyone's mind. Now, one of the muddling dimensions of this conversation, as many others I've had, is that medical travel is not a homogeneous single business. It's really quite a range of vertical service lines. So the difference between an individual who seeks a hair plant in Turkey, Giselle, from the UK, or dental work in Hungary, as Arlen suggested, that person is decidedly different from the individual who is in Turkey and is desperately seeking care for a highly complex cancer treatment that their 10-year-old son has. Those quote unquote markets, what motivates those individuals, the complex array, the constellation of issues around the provision of service for those distinct groups couldn't be more different. The only thing that unites them is that they cannot or choose not to obtain what they want or need. They are. So there's a cross-border trade. And in some ways, Giselle, I admire, and in other ways, I would admonish the perspective that the risk of imports, so inbound is exporting. Avoiding those risks, you can't avoid them. You can't, they are there. And the fundamental response to this is, well, how can I ensure against the risks, the latent and overt risks? And there are insurance policies for this. So there's an association or an organization that features these things, the international travel insurance markets, and people who travel for care, not for people who are traveling to get drugs in Canada or get what they want in Mexico and bring it back supplies, but people who are traveling for care from the UK, even if it's just a hair transplant, there should always be some type of insurance cover that attends that individual. Because even in the best of circumstances, and I happen to know these numbers quite at hand, as you said, Giselle, according to the best data in the UK, roughly 13.5% of all procedures require readmission to a hospital. And that's similar to the data in the United States. It's higher in the United States. But that means, some significant proportion of people that go for some secondary care where they need to get treated in a clinic or in a hospital by a trained professional, secondary care, as opposed to primary, tertiary, or quaternary, they will go back. They will need to be retreated again. So that means that if you bring someone into the UK from Turkey or from another destination, some percentage of those people will have complications when they return. And we, I believe, in these markets have been ignoring that dimension or frankly, wishing it away. And that's imprudent. I think we need to take responsibility. First of all, it's a branding issue. And it's also I think it's an ethical issue. It's the right thing to do. So the first thing is risk. What is the risk associated with the travel? And how can I help cover that? And this also ties back to what Arlen said, Giselle, just before you made your excellent observations about why Medvoy, the med-to-med model that Arlen created, and we had several conversations about this, Arlen, one that started in Cambridge at a coffee shop right outside of Harvard University about this subject, is that the medical malpractice cover that doctors and hospitals obtain, that covers the risks that attend to the services they provide, that medical malpractice coverage generally is very jurisdictional. It's very constrained. It's very parochial. So one has to look not just at, can I get the people here safely? I'm thinking of this now from your perspective, Giselle, imagining you as the clinician. Can I get the people here safely? Yes, you can. Can I manage them while they're here and while they are receiving their treatments or their procedures? Yes, I can. Are they going to be attended to and treated by the very best? Yes, they will be. Can they then return and safely recover, recuperate, and return to their highest and best status? That's the biggest risk factor that's really out of your control. And there are some insurance products for that, but there also needs to be a change in the way we who are in the business look at that last leg to complete the cycle. I hope I haven't blathered on too long.
The other issue is, can you get there safely? Yes. Are you safe when you get there? Is the issue with Mexico and the issue with other places. And actually, when I asked a bunch of doctors at this meeting, what is the single biggest issue you have to confront when you're trying to get or encourage patients to use your services in Mexico? Security was number one. And in fact, the Minister of Security for all these different states in Mexico was one of the speakers, and they just kept talking over and over and over about, no, it's not true, and what you're reading in the US press is biased, and yeah, sure, it happens, but New York is more dangerous than Monterey, et cetera, et cetera. But the fact of the matter is perception is reality. And to your point, people are afraid to go to certain places because of what they read or what's in the press. Now, how you control that, obviously, is probably beyond your control, and God knows governments, it's beyond some government's control. But that's a reality. David Groves, I want to engage the rest of the people in the audience. David, where are you from? David, can you hear me? Maybe not. Emily, are you with us?
Yes.
Emily,
Great. Oh, Emily, tell us who you are and where you're coming from. Who are you?
I am in Boston, Massachusetts,
Yeah,
and I work with Irving on a number
I
of
see.
projects.
Good. And what is your background?
I'm a writer and content creator, and
Right.
yep.
Okay. So let's again, I mean, we could talk a lot about a lot of different things, but let's talk about the physician entrepreneur piece.
yes,
And
Can I respond to Irving before we move on to that? And I do have to leave at 3. My apologies in advance. But
sure.
I think I think what you said, Irving, is absolutely valid. You made some extremely good points. What I will say from our perspective is that we choose not to do, as a company, as a business, we choose to focus on inbound medical tourism because we feel as if we have more control and more understanding of the clinical systems in the UK, and more confidence in the clinical systems in the UK. And one of the things that we do as a medical concierge company is that we tend to use the best private clinics and hospitals. And the best private clinics and hospitals in the UK have a policy whereby this is about the management of clinical risk, because it's always great when things go well. It's what happens when things don't go well. Healthcare is about managing risk, because there's always risk in healthcare, no matter what you're doing. And so we tend to use the clinics and hospitals that have a policy and that adhere to a policy that states that if a patient is readmitted within 30 days of having a procedure, then they're bound to fix whatever that problem is, address that clinical issue. And that gives the patient some kind of insurance in itself, that if something goes wrong, then there's a commitment to work with that patient to fix it. And that's really important to us.
well, I respect that, Giselle, and that certainly makes a lot of sense. And most hospitals, most providers, beyond most, virtually every hospital, every provider will stand behind what they do. The problem is that in this cross-border trade, in this mode 2 cross-border trade where the individual travels across the border, your consumer, your customer, your client is already back in Turkey. And when the complications arise there is when the cover is necessary. And the rate of this, the opportunity factor for these errors is well known. It's somewhere between 13 and 15% of the cases from the best clinic will have complications, because you can't control the behavior of the consumer, you can't control the environment, you can't control the travel factors. There's a host of variables. So I'm not suggesting that you change your business model. I'm suggesting that each time you bring a consumer from another country, that service include medical travel cover, so that should there be a need for recuperation, for follow-on treatment, that there's cover available for that when the consumer returns back to Turkey or wherever she's from.
Sure.
Let me just interject and change this a little bit. Thanks for the comments. I think we're all learning something. You alluded to business models, and I just want to talk on that point, because again, there is no one medical travel business model. Specifically, for example, a third-party business model, which means a patient from Denver, this is going on, and those of us in this area know this. A patient from Denver requires or consults with a doctor in Florida saying, I want XYZ, second opinion, procedure, whatever.
Yep.
The doctor in Florida says, great, I will meet you in the Caymans for your procedure. because I have set up a cheaper, better, faster, smarter hospital in the Caymans, and which allows me to deliver your care. And the pitch generally is, because the hospitality portion of this will be much better. You'd rather be in the Caymans than in Orlando or wherever. Secondly, I can get a much cheaper rate doing the surgery in an ambulatory surgery center in the Caymans, parentheses, possibly part of which I own, that allows me to do this more affordably. So instead of $10,000 for your nose job, I'm going to do it for $2,500. And again, then, so the patient then goes to the Caymans, the doctor goes to the Caymans, the procedure is done in an ambulatory surgery center, you stay in a 5-star hotel overnight, and then everybody goes back home. That is one business model that presents an entire raft of issues, many of which we have just described.
Yes.
Not the least of which is conflict of interest. The second problem or issue is, and I'm interested in Giselle's opinion, is the whole issue of medical facilitators. Now, again, you're in the business, Giselle, of doing this. So what I'm proposing or asking is, some people would think that the middleman or middlewoman, that is the medical facilitator, who is arranging the care for a patient between Turkey to the UK, and I'm presuming you're not doing this for free.
No, we don't.
Right. I'm assuming that you charge for your service. Now, some would say that the company that you, or the doctor or hospital that you refer the patient to, either directly or indirectly, is subsidizing your income. Now, I'm not accusing you of anything, and I'm not saying that's the case in your case, but some people argue that this is fee splitting, and that the whole issue of medical facilitators arranging care, it's no different than a travel agent or any other middle facilitator. So how do you respond, Irv and Giselle, to that accusation?
It's not an accusation.
No, it's not.
Unless your ethical frame of mind puts it that way. Giselle is providing a service which the consumer otherwise wouldn't be able to access. So she is facilitating. She is the agent by which the consumer is accessing services which the consumer wouldn't have been able to access, or chooses not to go through the trouble of accessing. So and the issue of fee splitting is it's a fabricated ethical dilemma. It isn't, in my opinion. Now, have I met unscrupulous facilitators? Yes, Arlen, I can tell you about one that's still in jail, but that's not what we're talking about. We're talking about people who provide a legitimate service to a willing and knowing consumer that arranges services by a willing and knowledgeable provider.
Exactly. And that's exactly right. What we do, Arlen, is this. We are not tied to a particular hospital or clinic. We act as agents and advocates for our clients. So there are other medical concierge companies in the UK, but they tend to be attached to a particular group of hospitals or clinics. We are not. We're completely independent. We start with what the client's needs are. We don't tend, and then we work from there. So we select a consultant and hospital or clinic based on the fact that we are passionate about getting the best outcome for our clients. That's what's most important to us. And in 98% of the hospitals 99.5% of the hospitals and clinics that we work with don't pay us a bean. There are 2 hospitals in total that we formulated partnerships with. And if it so happens that the needs of the client could best be served by using their services, then great. But our foremost responsibility and focus is what are the needs of this client. So they're paying us to be their advocates, and we give them a choice. We say to them, here are 3 consultants who we think are fantastic. You can either choose one, or if you'd like us to select one on your behalf, you can then research that person and make sure that you're happy to be treated by that person. We help with all the other logistics, such as accommodation, airport transfers, transport. So it's a complete package that we provide to them.
So I think what Giselle has just done is rewritten the brochure for medical travel facilitation. So thank you, Giselle. But she brings up 2 issues that we haven't touched upon. We've touched upon risk, and I believe strongly that managing risk is a central part and a less emphasized part, and something that I have written about recently and will continue to write and speak about in the medical travel and the health insurance arenas, just covering that risk for that 15% of the situations where complications occur, even though the provider is the best, the consumer is well aware, et cetera, et cetera. So there's always that risk. The other thing that we haven't talked about that Giselle brought up is choice. So the consumer in these markets, the consumer has agency in choice very often. There's some extreme cases in quaternary care, the most complicated things where choice is really not so much it's who can do this and can I get there kind of a thing. But the factor of choice is extremely important and not well understood. Many people, such as you even alluded to it very early in the conversation, Arlen, talking about cost. Many people in the cross-border trade business believe that price and cost is what drives decisions, choices. Very often, however, price is in the mix, cost is in the mix, but it's not the principal driving factor. And we've done some research to prove this. It has to do with familiarity and access. It has to do with some latent characteristic of what the person, how the person believes, or how the person believes something about herself that drives the choice about where to go, how to go, and which provider to use. So Giselle talked about managing these choice process, assisting, but really the choice is completely asymmetrical. Consumers are not able to choose providers rationally. Now that's a big statement, and I'm completely prepared to have another conversation to back that up.
Yeah, you're right. And the point, well, first of all, people buy emotionally and justify rationally. So the whole issue of, and the second issue is, this really has to do with patient information and shared decision-making. And so to your point, this reminds me of, when you hire a travel agent or a wealth manager, is that wealth manager working on a contingency basis? Is that wealth manager a broker? Is that wealth manager a fee-only planner? I mean, there are a lot of, and that's why I bring up this issue of business models. And your point is, like insurance brokers and everybody else, now lately realtors, all right, I'll be right there. People don't understand the differences between one and the other. People meaning the patient. So I think it's our obligation, and everybody agrees with this, to do a better job of educating patients. Of course, we run into issues with how do we get that done internationally and who's involved. We're going to have to I mean, we could talk about this a lot, and I really appreciate everybody chiming in and giving their 2 cents. Thanks for joining us, and hopefully we'll have 5 other sessions dealing with all of these issues. Thanks a lot for participating, and stay safe.